good morning, everybody. Welcome to Grand Rounds, and it is my distinct honor to introduce my senior partner and brother, Dr. Laligam Sekhar. He does not need really any introduction. Everybody knows him across neurosurgery and beyond, but I think what is important to recognize about his talk is the spirit of sort of relentless innovation and problem solving that Dr. Sekhar has shown. And I think if you look through his voluminous CV, you may not realize that despite sort of revolutionizing modern skull-based surgery and vascular surgery, his perhaps most cited paper was one about ventriculoperitoneal shunts. So there is no topic that Dr. Sekhar has not had an influence on within neurosurgery. And I think what is important to understand is that while things like shunts and cranial plating may not be what you first think of when you think of innovative, exciting neurosurgical research, it is extremely important. And these things affect almost all of our patients at some point. So thinking about these problems and approaching them in an innovative and curious way is the way to move the field forward, even if it isn't as show-stopping as basilar aneurysms or bypasses. So with that, I would turn it over to Dr. Sekhar, who's going to discuss cranial plating, titanium and absorbable plates, comparisons and innovations. Dr. Sekhar, please take it away.
Good morning to my great colleague and brother, Dr. Levitt, from whom I continue to learn, and spirit of innovation in our department is really raging, and not the least bit because of his work and all the others here. It's a great, very innovative and wonderful department. I have an entire talk about innovation another day, but so today I'm going to spend a little time about cranial plating, titanium and absorbable plates. Comparisons and innovations. I want to gratefully acknowledge some people that have worked in our lab. Landon Basner, who's a medical student, fourth year, spent a year with Dr. Levitt and I. Fatima, whom you all know, El Ghazali, she's a neurosurgical resident. Dr. Shenoy is a research fellow. And then we have two fellows, Chris Seward and Tyler Razaro, who've been cut loose, and they've been launched into the wilderness, one in the Midwest and the other in the South, not deep South, just South. Jason Barber, statistician, and Dr. Susarla, who's a plastic surgeon. So in terms of disclosures, I have a minority share stake in a company which has nothing to do with the research. The project was supported by Laligam and Laligam professorship funds, KLS Martin unrestricted grant, and also Department of Neurological Surgery. So this is the summary of this particular lecture, and if there's time. So if we have time, we'll talk briefly about some of the other things that are going on in our lab. This is a summary of the lecture after electrocraniotomy in adults. Titanium plate, disc and mesh fixation became the norm somewhere around 2003 or maybe slightly before that. There are several immediate advantages. These include immediate fixation, very quick, cosmetically acceptable, and also reimbursed, which is very important. However, there are late problems started manifesting in a number of my elective surgery patients. And as you'll see, it's probably an underestimate. These include plate extrusion, some infections, and so on in patients. I started doing these types of cases on a regular basis every week, about one case, but I had to go back and do something with my patients who had titanium plates. So I started using absorbable plates. These are plates that are made of polylactic and polyglycolic acid and bone cement around 2023. These were already used extensively in pediatric cases, but not in adults. The downside is the immediate fixation is not as strong, but it seems to be more acceptable over time. However, we have noticed on some problems on follow-up. tenderness at plate sites, depression at the sites of burr holes and craniectomies, despite the use of bone cement. So we made certain changes. We call this underplating and overplating. And then we also have some new innovations which require further studies. So we'll talk about all of this. And I already mentioned our research team. Also, Amy Anderson, who was our clinical research nurse, very important to get all of our projects through, and also then they are subject to review afterwards. Um, Brief history of cranial fixation. A long time ago, they were just fixed with sutures. And some of the people in the audience obviously remember metal wires. We used to use these, pass the wires through holes and then twist them and leave them. This is the way I was raised when I was a resident. And then we started using stainless steel metal plates. These migrated to titanium plates and discs, non-magnetic. By way of introduction, titanium is a very expensive material. It doesn't occur naturally it occurs usually in an oxidized state. A lot of it actually is mined in Russia and faraway places. And then medical grade titanium is produced and then created into very elegant plates. In fact, I visited a factory in Germany where these are placed, these are being made very nicely. Now, absorbable plates are made of, as I mentioned, polylactic acid and polyglycolic acid. They were used extensively in children, not in adults in the past. So, as we mentioned, we started having these problems that I identified in number for elective cases. So, the study has four parts to it. The first part is we did a retrospective study of patients who presented with complications after revision. And these are only my patients, much more difficult to find patients of all the other folks here in our department. And we excluded neurotrauma and stroke acute cases. 41 patients met criteria, and during the same period of time, there were 3,000, some 233 cases, and statistics as you see here. So we found the overall revision rate 1.27%, and mean age, and there were three pediatric cases. These are older pediatric patients, usually operated for AVMs or some for aneurysms. And you see here the different approach. We classified the approaches into five groups: frontotemporal, retrosigmoid, farlateral, bifrontal, petrosal, and suboccipital. And these were the comorbidities identified. And the timing of the wound revision, and you could see the median day is about 1.5 years, but some of them occur pretty late as well. The main issue is that all of us, and I never thought about it in the past, as we get older, our skin, particularly over the scalp, loses a lot of subcutaneous fat. So our skin gets thinner. And then to add to that, if you have radiation therapy or something like that, or a mild infection, it gets magnified. So you have these types of issues: infection, cephalgia, hardware erosion, wound complications, etc. So in this study, we found that no comorbidity was statistically significant of any revision category. There were certain trends identified: blood thinners, smoking at approach identify significance. Age was not an issue. Radiation therapy, but probably not a lot of my patients get radiated. Only people with chordomas or aggressive meningiomas. But if you start having people with glioblastomas and so on, maybe many more. And I don't have a lot of those patients. Just one illustrative case. This is a patient who had three operations for clivus chordoma and is actually alive without tumor now many years. And you could see that he had these types of weird skull, and he is eroding through. However, this patient has refused to have anything done for this, and you can see it's a pretty bad looking thing. And it's not actually eroded through. He also had proton beam radiation afterwards, and a lot of sinking, etc. And how the plate is eroding through. And we have a few of these folks that are not didn't want to have anything done. You can imagine that reconstruction of something like this would be a horrendous affair related to involve plastic surgery, rotate some flaps, etc., and whatnot. So we did not query all the 3,400 patients electively. So I think the actual percentage of problems is probably going to be higher. I'm aware of two patients who were then seen elsewhere, and the neurosurgeons called me, and then they did revisions. And then some people who didn't do anything or didn't come back for follow-up. So the denominator is just a baseline for prospective evaluation. So then it raises the question, is it, even if you assume that it's, let's say, 2%, is it enough to make a change in the practice? If the change can be done without major problems, it can be done. Of course, obviously, there's already a precedent in pediatric cases that were being done. So I started using absorbable plates initially, and we were using a combination. I was using absorbable plates for the most exposed areas, but if it's under the temporalis muscle, we were still using some titanium mesh, etc. But then we gradually moved away from it completely, and we did a study, the part two, which is somewhat incomplete because we need to get some more data. And this is a retrospective comparison. This is not a randomized study, retrospective comparison. By the nature of the study, we have people who have much longer follow-up with the titanium plates. So basically, the groups are kind of matched in terms of the age and various comorbidities, and also they were matched in terms of the five types of approaches which I identified. And we looked at the outcomes. And even in this group, we found that revision surgery for plate-related issues was about 31% titanium, and absorbable plates. There were none related plates, but some were take-backs for other reasons. So 11% in this group, which was statistically significant. However, we did identify some problems. That is that you see here, this is a patient with a petrosal approach. This is a convexity or parasagittal tumor, and this is a retrosigmoid. And the places where we have Burhouse or craniectomy sites, even though we use a bone cement, there is a depression in these areas. For some patients, it doesn't matter. For other people, actually, they can feel it. And these days, everybody's worried about their appearance. And when they comb the hair or whatever, you can't say that it's women, it's even men notice it. And of course, if it's on the top of the head, then it's even more noticeable. And if it's in the corner, it's also, again, it can cause sinking and so forth. So we then moved to, so this is the group that the immediate stability is less. We did not look at that aspect, because the only way you can look at it is biomechanical studies. And we didn't do that. And I have no doubt that biomechanically, the immediate stability with the absorbable plate is much, much less than titanium plates. However, over time, no one has any issues, and we have looked at how does a fusion occur. In both cases, there is a combination of both fibrous union and a bony union over time, and we are able to document this. We couldn't find a way to do it scientifically, to what extent the bony union occurs and fibrous union. In both cases, it's very similar. So we moved on to what is called cranial underplating and overplating technique. So what is underplating is we provide a buttress for the bone cement in the butthole and craniectomy sites. After that, the overplates are used to secure the bone flap as usual. The underplates are made of polyglycolic lactic acid and 0.3 millimeters in thickness, and you'll see what I mean by underplating. So here's a bone flap that on the top left, and you can see that we put the plates under on the underside, undersurface, and then we flip it, and once the flap is in place, this is an overplate just to secure the plate, and then we are able to put the bone cement. This does two things. Number one, it doesn't sink or create holes, and number two, the bone cement does not directly contact the dura mater. So these are some advantages here. Now we started this about 6 months ago, and at the moment we are proposed and we actually been approved to start a prospective study of patient satisfaction, appearance, CT scans, and complications. We're planning to study about, I think, close to 100 patients. So this is the beginning or early underplating. This is a young lady with a big AVM in the occipital area. And you could see that we still have a gap here. We didn't do a great job, but for the most part, and this is what it looks like. The plate gets absorbed. Absorbable plates, they go away with time. Some of the patients are able to feel it. They feel some inflammation. They feel some tenderness, but it goes away after 2 to 3 months. And this is a patient after ACOM aneurysm clipping. Again, we didn't do a really great job at these sites, but the patient couldn't feel anything, and cosmetically very acceptable result. So in order to evolve this further, we come up with two innovations, two absorbable plate designs. The one is called the burr hole plate. So what's a burr hole plate? Essentially, instead of having an overplate, this is a plate that is inside the burr hole. So here's a view from the bottom side. So it's attached with two flanges to the bone flap, and then it fits in the burr hole. And there are prongs like this, and you can just put a screw through this. Essentially, these are all absorbable screws. So the plate, first of all, attaches the bone flap. So you don't need to use an overplate. And then there are prongs here to act as a scaffolding. You can fill this up with a bone cement so that this whole thing is covered. And if you have a larger defect, the largest one we've envisioned is just 4 by 4 centimeters. Keep in mind, this has not been actually used in any patient. This is a design proposition. So this is essentially an underplate. For example, in the retrosigmoid area, we might use this, or in the frontotemporal area. And then again, it sits on the underside, and these flanges can attach to the bone. And then this can be filled up with. And why do you have these little struts? And this is just to act as a basis for concrete. So these two designs, a provisional patent has been submitted by UW, and it's gone through the process here. It's a very complicated process. We had to go through UW and NDE and so on. At this point, we'll need a joint development with a company to see how these are working in the future. So that is the first part of the talk, and I'm going to stop here for questions and discussion, and then I'll move on to another short, brief other things that are going on. Invite any questions or discussion.
Questions for Dr. Sekhar?
So the one of the questions that might be asked, why are we so worried about all of these things, appearance? We are all moving to an era of patient satisfaction. This is the most important thing after anything. And when the patients don't feel it, some of the patients that you see in the clinic, they complain of headache. So when they complain of headache, then they started feeling these titanium plates and they become fixated on it. I'm not sure that the titanium plates actually cause the headache, but they become fixated on it. The other thing is that if there is some depression, etc., people don't like it. And this becomes a major issue of our own body image. Essentially, body image is very important. If you don't, if you just don't think about it, if you feel like there's nothing there, then you go on. But as long as you feel like, oh, I got something here, I got a little depression, so on. So people are not very happy about it. So I think, as we compete, essentially any microsurgery or any cranial open surgery, it competes for the most part, rightly so, with both endovascular techniques and also radiosurgery. So you got to be thinking about, how is that a real advantage and how does the patient feel about it? This is very important. So um, the downside, of course, as I mentioned, is that the immediate stability is not as good. And I always tell the patient, they always ask me, Dr. Guy, what can I do and when can I resume normal activities? Even after titanium plates, we tell them wait 2 to 3 months before you go skiing or diving. Or if they were to be involved in an automobile accident, how stable is that, that construct? That's always going to be a question there.
This is Jeff. I have two questions. First, thanks for covering this topic. When we use it in the kids, I always warn the parents that they're going to see a bump in several months, and they always forget. So I don't know if you have a hint on how to prepare people for that inflammation that happens when it dissolves. And second, how confident are we with complete dissolving of the substance? Because I know these aren't plastics, but when you get into these micro or macromolecules, there's a lot of concern about what the longevity is and what the impact is. And I was never fully confident that these things completely dissolve into elemental form. So I don't know if there's evidence on that or not. Thanks.
I think they're both very good questions, Professor Ojiman. So the first one is that um, we, I would say that about 10, 15% of the patients complain of some tenderness when we see them in clinic. I don't, we're going to be launching this prospective study. We're going to have to warn them about it. But in general, we haven't been telling people, but when they come and to the clinic and complain of tenderness, we tell them, oh, these are the plate sites, and I show them where the plates were implanted, and they're very happy. It goes away at a 3 month visit, completely gone. In terms of absorption, we have delayed CT scans, delayed meaning after 2 months. We can see the plate site essentially, and just like I showed one case where the holes were made and so on. And I can't talk about different companies because there are 2 or 3 companies that are making these things. The KLS system is much easier. Our residents and fellows uniformly prefer that because it's an automatic screwdriver. You just put the screw and then it's very quick. And the screws seem to go away. We have not measured the microplastics. That's a real question. Microplastics, they clearly are being absorbed by the body, and what's happening to the body in terms of what we call microplastics, we don't know. That's being raised as a concern these days. So the material, however, is supposedly excreted by the kidney. So I just don't know how to. Certainly, when we see them at the 2 months and later scans, mostly they seem to be gone. And then we also frequently we get CTAs in all of our vascular patients. And sometimes in tumor cases, we get CT scans. You just don't see, you do see the evidence of where they were in the past. Okay, so there are no further questions. So I just want to mention briefly about some other projects going on in our lab, and we call it the Brahman space. Brahman stands for space and time, and so it's a redundant. So my idea is that all new ideas and innovations already exist there, and it's just a receptive mind grabs them. Therefore, in reality, they don't belong to anyone in particular. The receptive mind can grab them, but people that develop these ideas also require a lot of credit, and it requires a lot of work, and it raises an entire idea or concept of patenting. We need patents and licenses and so on in order to make money and in order to incentivize people, but reality, these things don't belong to anyone. So we have a number of clinical outcome studies going on. They are all of the outcome studies are jointly with our cerebrovascular team, comprising Dr. Kim, Dr. Levitt, Dr. Chen, Dr. Gotke, and Dr. Walker. So a lot of this involves data collection and AI-based analysis. Examples are just we're looking at fetal PCOM aneurysms, ACOM aneurysms, etc. In the past, I've given this talk about the augment flow internal jugular vein massager. This is kind of at a crossroads at the moment. We need more funding to do more studies. So we don't have any more. We have more grants being applied for. So one set is being applied, and we're looking at MRI compatible device so that we can document exactly what's going on when this device is activation. The next project, which is a weird one, is called the AI-enabled robotic assistant during microsurgery and spine surgery. You're all familiar with robots for spine surgery and also for functional neurosurgery. But my concept is that we need a really good assistant. Of course, in university academic situations, we have we have very good assistants, and the higher up they get, the better they get, and some of them better than others. But then they gone. So, however, in private practice and many other situations, this it won't be existing. So, and even in the universities, as we get more less resources, it'll be an issue. So we have a team of people. We're working together. So the idea is to create a robot that will first work on the basis of surgeon's command, and then it'll intuitively do what the surgeon wants it to do. So we have a team, and believe it or not, the most important members of this part actually has two studies to it. One is we are doing studies. We're actually not started them. We have a grant pending, IRB studies pending. We want to understand what the surgeon and the assistant are, how they're interacting, and how is the assistant helping the surgeon. We've done some studies by analyzing videos, but now we are actually going to be looking at live situations. For example, when Dr. Levitt or Dr. Kim or also our spine surgeons, they are operating, how is the assistant helping them? And how do they know? Is it the surgeon telling them, suction here? Just suctioning is one of the simplest things they do, but it's very important. Suction here or grab this. These are the two things they do. So, and then we also simultaneously innovating a 3D printed robot, which is table mounted. And we also created a virtual robot. So virtual robot is working with a master AI program called Chief is Next. I'll show you that in a minute. So we already have a 3D printed, so this work is done, believe it or not, by two high school students who are now just entering their rising seniors. They are whizzes at robotics, and they are distantly related to me. So they already created this 3D printed robot, and basically our idea is that we have skull model, and the robot will act on surgeon command. So the surgeon is also going to be another robot. So there'll be two robots. The surgeon will do some action, and this robot will start working according to the surgeon's command, voice activated initially, and then it has to follow a chess grid wherever the surgeon is, the robot has to be in the next square, essentially. And it has to come through a narrow space, which is really the craniotomy, and not interfere with the surgeon. You think about it, very complicated things are happening. And we have learned this, of course, through evolutionary process. It's not going to be an easy thing. But I think that the idea is not to replace the surgeon, but to help them. So this is a project that is actively ongoing. The next project, which is a dreamy project, I say dreamy because it's not it's a real project, but it's a virtual project. This project is called the Lunar Base Hospital. So the lunar base is going to be established in my lifetime, but an actual hospital may not be. We're thinking 20 to 30 years ahead. If we establish a real lunar base, what will a medical need be? Because without you just can't transport the people out of the moon to achieve surgical and medical care. And this is kind of this diagram needs to be modified, but this is a proposed lunar base. We haven't really established where the lunar base is, what's the ideal location. This is called the Shackleton's crater, which is a shaded part of the moon, permanently shaded. The key limitation on the moon is water. How much water is there? We don't know exactly. There's a lot of guesses but it's going to be one of the next missions, Artemis missions. So the idea is going to be there's going to be energy, water, energy, and disposal are key elements of anything, any permanent settlement on the moon. And our concept is a hospital that will be a part of this lunar base, but it's a phased approach. Initially, just a planned lunar landing, emergent medical and surgical care. Phase 2 is lunar clinic, and then as the population expands, it'll be a small hospital. But this has forced us to think very actively about a lot of things that we take for granted here. For example, I go in and out of the operating room every day. I throw out so many things: head caps, gowns, this, that, and the other. A lot of our equipment is disposable, thrown out. We don't really know where it goes. For all we know, it goes into a landfill. Some of that is dumped into the sea, etc. But in other countries, they have fewer resources. They recycle and use more of them. But on the moon, everything is going to have to be recycled or manufactured. Initially, will be going up and down. So we have this is a consensus-based development. This concept, there are about 28 Earth-based experts we have actively consulting with, and we're getting ready to send out a first paper on this one. And then we will go, and then this hospital will have a 24/7 terrestrial support facility, which will include communication, simulated virtual surgery, robotics. The problem, however, is that there's a 2-minute time, so it can't be really live. It's a little bit of a lag time. There's just transmission time is about approximately 2 minutes. But a lot of it can be done with the AI, and for example, we have already robots which are doing very well with endovascular therapy. Not going to replace the endovascular surgeon or the endovascular interventionalist, but the robot can do a lot of it, and it's going to keep getting better. So that sort of thing will be endovascular is actually going to be ahead in this lunar base because it's a 616 gravity on the moon. On the other side, there may be increased hypercoagulable state due to radiation, etc. So that's a downside there. So in this one, we also very actively working with artificial intelligence. And again, I have always some kind of advantage. This guy is my older son. He has this agent called chiefisnext.com. It goes and grabs whatever agent that is already there, Anthropic, OpenAI, Google Gemini, and there are a lot of other artificial AI agents. and allows people like this to work on this project concurrently. And this is in the early stage of development. But it's a sort of an exciting thing just to keep the mind going. This I feel like this is the early days of let's say skull base or endovascular surgery. There's a lot of developed team-based people that are coming together and thinking about some issues, which we think will have some impact on Earth-based problems. So this is one of the reasons for this project. That's where we are with this one. Stop there, and then again, questions and discussion on this one. Dr. Haynes. Clearly, the earlier studies are not randomized prospective control trials, so we don't know. And you can
They never
find a
are.
lot of holes in it. Yeah.
They never are. But there are advanced techniques coming along that make it easier to dissect the various confounding factors. I mean, you've mentioned all the difficulties in collecting the kind of data necessary to assess these things. But the techniques are improving, and larger amounts of data continue to improve our ability to work without the magic of randomization. But remember, randomization is the only thing that can control things you don't know about yet. It's magic. So, as long as, it was mentioned that the area of shunts was your perhaps most highly cited paper. My most highly cited paper is actually one on the early filling up of holes in the skull. So, these things just happen. I'll
Yes,
see you on the road
earliest
someday.
paper was what I did was I was investigating why shunts get blocked. So we used to do shunt revisions, and then I analyzed the material that was blocking the shunts, and we found some very interesting stuff, including talcum powder and this and that. They were mixed up with the stuff that was being removed pathologically. So it was very interesting.
I remember it well.
Professor Levitt, you have some comments about the directions of the lab and also what I want to mention, for example, I learned a lot by looking at his lab because he is clinically extremely active at the same time has a very active lab, and he has multiple auto-1s, etc. He's got a constant stream of people, young people working in his lab, and it's very inspiring to see how young people, meaning and students and aspiring students, aspiring neurosurgeons working and being mentored, and it's a complicated process because they sometimes don't finish things on time, or they may be doing things that you don't know about, or they're not, collecting data outside the range of the study and so on. So do you have some comments about that?
Thank you, Dr. Shaker, and thanks for the kind words. I think the through line the through line to all of this is just to be just to be curious and to bring your enthusiasm. Don't be pigeonholed into just looking at one thing, right? I mean, you're an example of somebody who could make their entire career, let's say, just studying skull-based meningiomas, and you could make a whole research career out of that, but you don't stop with that, right? There's always something to be thinking about. And if people bring their enthusiasm, that's all you need, and you can harness that enthusiasm in any direction that you choose.
Can you comment on the process of this idea of being curious, and how does a neurosurgeon, how do you, first of all, inculcate that in our residents, number one, but more importantly, how does a neurosurgeon continue that? Because approximately, let's say 75% of the neurosurgeons who are trained will end up in a private practice setting, not academic, and it becomes more difficult to do something like, how do you, and is that important? And how do you continue that?
Yeah, I don't think being in an academic center is a necessary requirement for academic productivity, and I also think that it's just in some ways it's easier because of the tools that are around you, but not necessarily. But I think that what I would say is the greatest asset that people have when they start, particularly at a more junior level, is being naive. Um, be naive enough to try. Don't think that. Don't be cynical. Cynicism would say, "Oh, so I'm sure somebody's already solved this problem. I'm sure somebody has already published about this. I'm sure somebody's written that grant." Or I couldn't possibly write a grant about this. I'm not ready to write a NIH grant. I'm not ready to do a prospective study. And the truth is, you're never going to feel ready. But if you're naive enough to try, you'll see that you'll have more production, you'll have more success, and it's just about shots on goal. You know, the more tries you make to get grants, the more tries you make to study things and write them up and publish them, the more likely you are to be successful. So I think it's the enthusiasm, and then certainly it requires direction and mentorship to harness that and point it in the right direction. And then we always have to consider the confines of research ethics and compliance. You always have to do things the right way, which is very important. But I think even within those boundaries, just having a senior or junior or mid-level, doesn't matter, but some mentor there to point you in the direction, and then harnessing that enthusiasm, being curious and naive to try. That's the recipe for success, in my opinion. And it's easy when you do it that way, because if you're just curious, then following the curiosity doesn't feel like a lot of work.